We wear none of these badges with pride, but they just happen to be some local health challenges for our borough. I think what is interesting about our borough and being in London is that we talk about deprivation, but we have quite a different profile from a lot of the country, where our population mix is much more geared towards younger people, younger families. Part of our borough has a very high Bangladeshi population, and it is a place that's had lots of immigrants over many centuries actually. We've also got Canary Wharf, where we've got some of the most highest earning people in the country who work there, and we're in a transition where we're moving from an area that was old East End, kind of East Enders that you occasionally see on the telly, but it's not really like that, to one that's got this very, very diverse population mix, which is absolutely amazing in some respects, but does present challenges. And then gentrification going on, but it's all at the younger end. We haven't really got so many older people, and that does impact on, to some extent, how we look at our services. In terms of a collaboration and Tower Hamlets together, we have a number of parties in there, which would probably be the same in any of your systems, and we have us as a federation. Our journey on this started quite a long time ago, back in the mid-2000s, when we had some of the poorest primary care outcomes in the country. I guess our values and our mission and our aims are probably fairly consistent with a lot of systems. I think the important things in terms of collaboration is that all the organisations are actually signed up to them, so we start from a good base point. Through the Vanguard stuff, we had quite a number of projects that we were able to get going, focusing around kind of population health and what we might be able to do to improve health and well-being. Some work specifically around adults, and that picked up on some of the things we're trying to do through the Community Health Services contract and our approach to that, and a new model of care for children, which was integrating health and social services. And we've kind of been impressing on NHS England when they come to talk to us about how we're progressing on Vanguard. There's not one of these things is a single magic bullet, but collectively they do seem to be making some difference to the results we're getting. When we come to lessons learned, one of the things is that it's actually really quite difficult to work in partnership unless you are really committed to it and afford the time to it. I reckon I would have spent more than 50% of my time working with partners and actually in partners' offices than rather than in my own organisation. There's quite a lot of stuff that we're sharing between us and developing together, and one of them is our outcomes framework. What we're trying to do is shift away from lots and lots of KPIs. I think the original Community Health Services contract had about 450 KPIs in it, something ridiculous, and trying as a system to say, well, if we share the same values and aims, can we develop a set of outcomes that we aspire to achieve, and then make sure that everything that we're doing is focused on, does it deliver that outcome? So the outcomes are based on, as it says, around me as the individual, what I expect of my doctors and nurses and social workers, and what me is all about. And these are expressed as I statements. I feel safe from harming my community. So when we're doing, when we're thinking about services and service changes, we're kind of thinking, what does that deliver in any of those? That's been developed with with local authority, with all the partners in the system, and it continues to be developed. And the Community Health Services contract that we're working on has a payment element linked to delivery of some of those outcomes. One of the things that the CCG introduced, which I think was particularly clever, was to set up a shared local incentive scheme. So they set us a range of objectives, and they said if you collectively deliver on this lot, and they, surprise, surprise, did include things like tackling non-elective admissions and bed days, but they also included, for primary care, general practice, we want you to get your flu jabs, your immunisation rates up to a certain level. The money was taken partly out of Sequin and also some out of Better Care Fund as an incentive pot. So some you had to kind of earn back to get back to your contract level, and then there was a sort of bonus payment on top. Through the collaboration, we've been benchmarking performance as a multi-specialty community provider against other MCPs and against the national average. And on some of these benchmarks, emergency admissions and bed days, Tower Hamlets is one of the best performing MCPs. I go back to the thing about no single bullet. It's actually quite difficult to tell you what specific intervention is making the difference, but nevertheless a collection of those things is making a difference, and this has been adjusted for the age point of view, so it's we know we're doing pretty well. So what we are moving to as a collective is a dashboard that starts to bring together information across all parts of our system that everyone can see. So I talked about the general practice journey, and we started quite a while back. In 2009 we formed 8 networks. Tracy and I joined in around about September, October 2015. We bid for a health visiting contract that the borough was putting out, and we were successful in it. And it was worth about 6.5, 7 million a year. And then we found we were successful in the Community Health Services bid. So over a relatively short space of time as a federation, we've grown from about 300,000 turnover. This year we're looking at about 23 million, and we expect to be heading towards high 20s next year. The CCG wisely decided that you needed to be co-located, so the networks are in groups formed around what were previously lapsed local area partnerships. They would be looking typically after a population of about 30 to 40,000. By putting the practices into small groups and then giving them some local incentives, that had a number of impacts on care packages, and it also started to get the networks to be looking at developing at a different scale, again moving from practice to a decent group of 30 to 50,000. When we got to the formation of the GP Care Group, being the voice of primary care at scale, we've pretty much established we're included in all the top table things within the borough, and that's great. The thing we're now having to focus on, having set ourselves up to be financially sustainable, is how we help the rest of general practice stay sustainable, because we've got, as I'm sure you have in your systems, a number of distressed practices want to hand back the keys, and it's kind of what do we do about that. The company itself is owned by all the practices, and I've talked to you about its budget. We actually currently have about 360 employees, so we really are quite different from where we were.
I think if you look at any tenders you see for good community services these days, they'll contain a number of the things that we've got in here. And that single point of access, back to the issue about how do you, from primary care, coordinate, pull on the right resources, know how to do that easily, quickly and speedily, it is a key thing for us. But it's also about how do we empower the individual so that we help them help themselves rather than necessarily come through practices in the first place, so that we empower them to find their own way around the services. Similar to every other good community service, it's about how do you provide a tiered integrated support around general practice to give good community services which do feel like that it's one team and an individual understands there's one team supporting them. One of the ones at the bottom, London, certainly in Tower Hamlets, actually the IT is pretty poor in community services. In fact, I've worked all around the country and it's one of the worst I've ever seen, to be frank. And so we don't have mobile working in community services, which feels for me bizarre, and so we're really trying to play catch up to support teams, because communicating and sharing information and sharing records is how you get that proper integration and you start to feel one team and you save time and energy. The responsibilities of the community contract is split between East London Foundation Trust on the left in the blue, Barts Health on the right, and then us as the Federation at the top. So the Federation takes the role of, and has taken the services which are about coordinating care, because we feel that's the best link to fit with general practice. We've got a very small patient experience team, which is absolutely vital, because that gives a focus, a very small team. It has lots of volunteers, which undertakes discovery interviews, etc., to look at, are we really achieving those outcomes that Chris mentioned earlier in a way that means something to our patients? Are we getting those outcomes? And that looks not at functional services, it looks at integrated care pathways, so it's holistic. So the impact that we are starting to see in some areas, it's early days, it's only started in April, but what we are seeing is more people manage the community. So we've already, very, very quickly through the services we've put in, shut 2 community wards because we're caring for people out in the community better. We're repatriating people better, and we're supporting them better in their homes. We don't have, we only have one nursing home in Tower Hamlets, the rest are residential homes. And it isn't that we're putting people, a lot of more people in care home beds, we're actually taking them home and supporting them there. So that's a real impact that we can already see. The middle one about integration is about, yes, co-location, but then about really seeing it as an integrated team, because I've seen it before. You get people who sit in an office and say, we're an integrated team, but the social workers are over here and the district nurses are over there, and so we're trying to get beyond that. We're now developing, like everybody else should be, good care, case management and care coordination. That's, I think we're a little bit behind the game on that one, if I'm honest, but so we're quickly playing catch up. But the one at the bottom, I suppose, is a real key one in terms of population health. We have 4 localities, and the network split into those 4 localities. And those locality boards we're calling health and wellbeing committees. And they have a wide range of partners, particularly practices though. And the dashboard that Chris showed you earlier, we're taking in particular to those levels to say, what can you do, what do we need to respond to at a locality level? And we're providing some small funding to them to help them get projects going, make a difference. And the contract is for 5 + 2 years. We each have a contract with the CCG, and then we have an overlaying partnership agreement, alliance agreement, which is a contract between us. And within that agreement, we have shared areas. So we have a proportion of the income is related to the achievement of our outcomes. That starts at 5% and it goes up to 25% over the lifetime of the contract. We have an alliance board that meets on a monthly basis, which includes the CCG. We have found, though, if we're honest in terms of experience, we've had to create an alliance provider meeting, because there's certain issues that you want to thrash out without your commissioner in the room. And I think one of the great things, because the procurement took so long, is the degree of honesty and transparency that is vital for good working, that you understand your own constraints, you don't hide them, you surface them, you share them, and you work out what you're going to do about them. We are now looking at, can we extend it? Can we think about including other services? So we're looking at moving urgent treatment centre into the Alliance contract and creating a new service which is primary care led rather than acute led, but without having to go through a procurement, because we can add it into this contract. And we're looking at, do we bring the local authority into it in a more meaningful way than what we've been able to? We're moving towards, how do we develop as an ACS, as an accountable care system, and within that, as an accountable care organisation in terms of the provider element of it. So there are different aspects that we're looking at in how do we work. Tower Hamlets Together has been a fantastic basis for this. We're quite concerned with the emergence of STPs. How do we keep a focus on a place-based emphasis for Tower Hamlets. We don't want it to get lost because we've done some really good stuff. We've got some good partnership working. It would be really sad if we lost that, and we think we could go backwards. So I've got a very, very busy diagram, but in terms of our ACS, we're seeing our Health and Wellbeing Board, which is led by London Borough Tower Hamlets, as being our way of developing an ACS for Tower Hamlets, because it's already there as a statutory body. It brings all partners together with 3 arms that work in and feed it. So we've got the Tower Hamlets Together Partnership Board, which has got all providers and all commissioners on it, all with equal numbers of votes. But then we have a focus for commissioning on the left, and we have a focus for providing on the right, so that we can work together, collaborate, but take things into the appropriate place. We've already got a stakeholder council in place, and we've got, these are the locality boards that I've mentioned, which bring in individual GP practices, because that sense of what you do at scale and how you involve people and create those links is really important to us. So this, as Chris said at the very, very beginning, it takes lots of time, means lots of commitment to partnership working. However, I think that we can see the benefit, and our partners can see the benefit, which is why they're happy that we continue and that we really take this forward, so that we can be in an ACS which does represent Tower Hamlets.